Today we'll be discussing hemophagocytic lymphohistiocytosis, otherwise known as HLH. My name is Rachel Hackett, and I am a recent graduate of the PGY2 Pediatric Pharmacy Residency at Lucile Packard Children's Hospital, Stanford, in Palo Alto, California. By the end of this presentation, I hope you are able to discuss the epidemiology, etiology, and clinical presentation of HLH, differentiate primary versus secondary HLH, explain the pathophysiology of HLH and mechanisms by which the medications target the cytokine storm, describe the role of HLH-94 protocol in HLH management, and identify the role of emapalumab in HLH management. I have no conflicts of interest to disclose, however, I will be discussing the off-label use of medications. I've listed two calculations on the screen, the Mosteller and Du Bois equations for body surface area, which will be used to calculate majority of our drug dosing. With the exception in patients who weigh less than 10 kilograms, we will still use weight-based dosing in milligrams per kilogram. The only exception to this rule is etoposide, which will use body surface area regardless of the weight of the patient. HLH is a rare but likely under-recognized syndrome that occurs in both children and adults and is associated with high mortality rates. At a large pediatric referral center, HLH was diagnosed in 1 of 3,000 inpatient admissions over a 2-year period. Primary HLH manifests shortly after birth, usually within the first few weeks to months, and accounts for about 25% of HLH cases. Incidence of HLH in Sweden was estimated to be 1 in 50,000 live births, with equal gender distribution. Median survival was about 2 months in untreated patients. Secondary HLH can occur at any age, and Epstein-Barr virus is the most commonly identified trigger. Primary HLH is a hereditary transmitted disorder primarily caused by mutations in the genes that control how the immune system kills virus-infected or other abnormal cells in a person's body. Primary HLH is triggered by infections, but cytolytic dysfunction may ultimately cause certain primary immunodeficiency syndromes, which are listed on the slide for your reference. HLH that occurs in a patient who has a strong immunologic trigger, such as an infection or malignancy, in the absence of a genetic disease which features HLH, is often categorized as secondary HLH. Common infections include DNA viruses like Epstein-Barr virus, cytomegalovirus, or adenovirus, bacterial, fungal, or parasitic infections. HLH that's associated with rheumatologic disorders is most common in pediatric adolescent patients with systemic juvenile idiopathic arthritis and Still's disease. Lymphomas and leukemias are common malignancies associated with HLH, particularly in T-cell or natural killer cell lineages. Treatment with chimeric antigen receptor modified T-cells or CAR-T therapy or bispecific T-cell engaging antibodies can be associated with cytokine release syndrome, which often mimics HLH. So this combination of genetic predisposition, your underlying inflammatory disorders, and triggering insults culminate together into this highly distinct state of hyperactivation and inflammation. And this so-called cytokine storm results in clinical sequelae, which includes unremitting fever, coagulopathies, cytopenias, and hepatosplenomegaly. Disease in HLH is primarily driven by an uncontrolled sustained antigen presentation to and activation of your CD8 positive T cells, which is amplified by interferon gamma release. The sustained interferon gamma release drives that activation of macrophage and monocytes, which releases inflammatory mediators such as interleukin 1b, interleukin 6, and these result in clinical sequelae, including the unremitting fever. For diagnostic criteria, these were originally derived by retrospective reviews of previous HLH cohorts and updated by the Histiocyte Society as enrollment criteria for the HLH-94 and HLH-2004 studies. Together, these criteria describe patients with predisposing immune deficiencies, significant immune activation, and subsequent immunopathology. Fulfillment of 5 of these 8 criteria, which were defined in the HLH-2004 trial, serve as a practical tool for diagnosis. The treatment goals of HLH include suppressing life-threatening inflammation, killing the overstimulated antigen-presenting cells, treating the triggering event, such as infection or malignancy, and replacing the defective immune system with an allogeneic hematopoietic stem cell transplant, which provides the best long-term cure rate. A commonly used treatment approach for primary HLH is based on the experiences of the Histiocyte Society HLH 1994 protocol. So the image on this slide depicts the treatment schema that was used in the HLH 94 protocol, which consisted of corticosteroids, typically dexamethasone, cyclosporin, etoposide, and intrathecal therapy in a subset of patients. Patients received dexamethasone daily during initial therapy, which was then tapered into pulse doses during continuation. Etoposide was given twice weekly for 2 weeks and then weekly thereafter during the initiation period. And in those patients with primary HLH, etoposide is usually given for that 8-week initiation and then followed by continuation, where it's given every 2 weeks. For secondary HLH patients, the continuation therapy is usually unnecessary because most patients achieve complete remission with less than 8 weeks of etoposide. Cyclosporin was not recommended until week 9 due to concern for elevated blood pressure when given in conjunction with full-dose dexamethasone. And for therapeutic drug monitoring of cyclosporin, it's recommended to target trough levels around 150 to 200 to help minimize toxicity. In the patients that received intrathecal therapy, this is mainly used in those with CNS involvement or neurological symptoms that persist after 2 weeks of systemic therapy. And they would receive weekly methotrexate given intrathecally for 3 to 4 doses to help control CNS inflammation. The first international treatment protocol for HLH was organized by the Histiocyte Society in 1994. At 6.2 years median follow-up, an estimated 5-year survival was 54%, and therapy induced permanent remission or kept the patient alive until transplant in 71% of patients. Based on experience with the HLH 94 protocol, the Histiocyte Society modified the 2004 protocol in several ways. The HLH 2004 included 3 new diagnostic criteria, which included elevated ferritin, low or absent natural killer cell activity, and soluble CD25. Bringing the diagnostic criteria, patients needed to fill 5 of 8 of these criteria compared with 5 of 5 criteria in the HLH 94 protocol. Additionally, due to high mortality during weeks 1 to 8 in the HLH 94 protocol, treatment in the 2004 protocol was intensified by administering cyclosporin up front, which aimed at increasing immunosuppression without inducing additional myelotoxicity. And regarding intrathecal therapy, given the beneficial systemic effect of corticosteroids, they were added to the intrathecal methotrexate treatment, which is recommended for a subset of patients. The results of the HLH 2004 protocol confirmed the efficacy of using upfront cyclosporin. However, the additional intrathecal steroids did not further improve treatment results. Overall 5-year survival in the HLH 2004 protocol was 62%, but this was not statistically significantly different from the HLH 94 results. So based on this, the HLH steering committee recommends the use of the HLH 94 protocol as the standard of care if deciding to use an etoposide-based therapy for HLH. Now we'll review the mechanism and pertinent clinical pearls for the medications that were used within the HLH 94 protocol. So starting with dexamethasone, this was used as the primary corticosteroid due to its ability to penetrate the CSF. It decreases inflammation by reducing cytokine secretion. It can be administered intravenously or orally, and it's commercially available in a variety of dosage forms, including tablets, oral solution, and injection solution. Of note, the oral concentrate and elixir do contain alcohol. And in general, corticosteroids are associated with an array of side effects, including weight gain, edema, elevated blood pressure, decreased glucose tolerance, increased appetite, mood changes, adrenal suppression, osteoporosis, or bone weakness or necrosis. Supportive care may include a histamine receptor 2 antagonist or a proton pump inhibitor for gastrointestinal protection. Etoposide provides selective deletion of activated T cells and suppresses inflammatory cytokine production. Etoposide is administered as an IV infusion over at least 30 to 60 minutes to help minimize the risk of hypotension. However, it may be recommended to prolong subsequent infusions if your patients are experiencing hypotension with the first infusion. Tissue irritation and inflammation have occurred following extravasation. Etoposide does require dose modifications in the setting of renal impairment, and although etoposide is myelosuppressive, cytopenias and liver disease do not require a dose reduction. So no dose reduction for isolated hyperbilirubinemia or elevated transaminases. And these are not contraindications for initiation of treatment, as these usually will improve with the treatment of HLH. High drug concentration and the rate of infusion, as well as the presence of the polysorbate 80 and benzyl alcohol, which are in the etoposide IV formulation, have been suggested as contributing factors to the development of hypersensitivity reactions. So our next medication is cyclosporin, which is a calcineurin inhibitor that inhibits the production of interferon gamma. Generally, it's administered IV or orally, starting no earlier than week 3 of induction once dexamethasone is tapered. And this is again to help mitigate the risk of hypertension. Of note, the oral bioavailability of cyclosporin is about 30%. So we may require a dose increase when converting from the intravenous route to the oral route. Adverse effects include diabetes mellitus, gingival overgrowth, thrombotic microangiopathy, hepatotoxicity, hyperkalemia, hypertension, infections, malignancy, nephrotoxicity, and neurotoxicity. Regarding drug interactions, cyclosporin does undergo extensive hepatic metabolism via the CYP3A4 system and may require dose modifications with concomitant CYP3A4 inhibitors or inducers. Therapeutic drug monitoring is recommended and aiming for trough concentrations around 200 micrograms per liter. Weekly intrathecal therapy with the antimetabolite methotrexate therapy is recommended for patients with CNS involvement, despite 2 weeks of systemic HLH94 therapy. Adverse effects include headaches, dizziness, blurred vision, and loss of balance. So now moving on to the next therapy is looking at the role of emapalumab, or brand name Gamifant. Emapalumab is the only FDA-approved treatment for primary HLH. Emapalumab is specifically designed to target and neutralize interferon gamma, which is a key upstream mediator of the pro-inflammatory cytokine storm associated with primary HLH. A global, multi-center, open-label, single-arm, phase 2-3 clinical study was conducted in pediatric patients with primary HLH, with the primary endpoint was overall response at week 8 or at the end of treatment. Secondary endpoints included time to response, duration of response until conditioning therapy, number of patients proceeding to hematopoietic stem cell transplant, and overall survival, both post-transplant and event-free survival. Additionally, they looked at safety outcomes as well. For the patient population, they enrolled 34 primary HLH patients, and 26 of these patients completed the study. The median age at study entry was 1 year, and majority received previous HLH treatment with usually either dexamethasone or etoposide. Dosing of emapalumab is based on actual body weight, and patients were initiated on 1 milligram per kilogram IV twice weekly with concomitant dexamethasone. Patients' dose could escalate up to 10 milligrams per kilogram based on laboratory and clinical response. Emapalumab should be infused within 4 hours of preparation through a dedicated IV line, and it does require low protein binding inline filter. A total of 34 patients, 27 whom were previously treated, received emapalumab. A total of 63% of the previously treated patients and 65% of the patients who received emapalumab at all had a response, and around 70% of the patients who received emapalumab proceeded to transplant. And these were all outcomes at week 8. For safety, 10 patients who received emapalumab did pass away, 8 before transplant and 2 after transplant. None of the deaths were considered by the investigators to be related to emapalumab. And of note, emapalumab was not associated with any organ toxicity. However, infection did occur frequently during the study. And as expected with this patient population, 1/3 of the patients had an infection at the beginning of the study. Jordan and colleagues reported the post-transplant outcomes at 1 year through an extension study for an extended cohort of patients with primary HLH who were treated with emapalumab. Analysis was performed on a total of 45 patients, which they separated into 2 groups. Patients were either previously treated with a conventional HLH therapy, and the other group was all patients who received emapalumab. About 67% of the previously treated patients and about 64% of the all treated patients proceeded to stem cell transplant with a median time to transplant of 84 and 101 days, respectively. Outcomes at 1 year report that the neutralization of interferon gamma with emapalumab permitted most patients with active primary HLH to proceed to transplant and was associated with a favorable rate of engraftment, GVHD, which is graft versus host disease, and survival estimates. For warnings and precautions, as previously mentioned, emapalumab may increase the risk of infections. Patients may require infection prophylaxis. Patients should not receive live or live attenuated vaccines during treatment and for at least 4 weeks after the last dose. Patients should be monitored for infusion-related reactions, and reaction medications should be readily available if needed. Regarding stem cell transplant, an allogeneic hematopoietic stem cell transplant is the only long-term cure for HLH. It's indicated for all patients with familial HLH, any CNS disease, or relapse. Upon stem cell transplant referral, patients will originally undergo HLH typing and search for a suitable donor. Patients will receive conditioning chemotherapy to create marrow space and immunosuppression to prevent host rejection of the donor graft. For additional information on conditioning regimens, immunosuppression, and supportive care in these patients, please refer to the core competency for stem cell transplant. So now that we've completed treatment for primary HLH, we'll move on to secondary HLH, which revolves around treating the trigger. So a thorough search should be done for underlying or associated conditions, as these findings may dictate treatment. Viral infections, particularly EBV, are the most common triggering factors of primary HLH and infection-associated secondary HLH. Targeting the EBV reservoir by B-cell depletion with rituximab may have therapeutic value. Macrophage activation syndrome may evolve in patients with underlying rheumatologic disorders in which HLH94 is not considered the first-line treatment. We can use a medication known as anakinra, which is an interleukin-1 receptor antagonist, and this may represent a valuable addition to cyclosporin and corticosteroids. In malignancy-associated HLH, a regimen including etoposide and corticosteroids may be valuable before or concomitant with start of tumor-specific treatment. For secondary HLH, a cross-specialty approach is recommended, including switching off the cytokine storm, treating the underlying cause, and treating or preventing complications. To dampen the cytokine storm, immunosuppressants are generally recommended in an induction maintenance paradigm. A personalized approach to tapering therapy is recommended once inflammation is controlled. In patients with underlying rheumatologic disease, long-term immunosuppression may be required. And in patients with infection or cancer, treating the underlying trigger with directed therapy is of utmost importance. Anakinra is a recombinant IL-1 antagonist which targets a central component of the cytokine storm. It is FDA approved for treatment of rheumatoid arthritis and neonatal onset multisystem inflammatory disease, but it is used off-label to treat a variety of inflammatory conditions. Most literature suggests initial dosing of 1 to 2 milligrams per kilogram per day, titrated up to 5 to 10 milligrams per kilogram per day as clinically indicated. Consensus guidelines originally recommend subcutaneous administration for secondary HLH cytokine storms. However, subcutaneous delivery may have unreliable absorption during critical illness. Intravenous dosing of anakinra enables a higher and faster maximal plasma concentration compared with sub-Q delivery. IV is preferred in patients with thrombocytopenia or hemorrhage, where sub-Q delivery is relatively contraindicated, or in patients receiving higher doses, greater than 2 milligrams per kilogram per day or 100 milligrams per day. Anakinra is generally considered to be effective, safe, well-tolerated, inexpensive, and has a compelling benefit-risk profile for first-line use in patients with secondary HLH. In 2020, a retrospective review of 44 pediatric patients, median age of about 1 year old, with secondary HLH showed that earlier initiation of anakinra within 5 days of hospital admission was associated with reduced mortality. Intravenous immunoglobulin, also known as IVIG, inhibits complement activation. We consider initial dosing up to 1.6 grams per kilogram split over about 2 to 3 days, with the option to repeat the dose in 2 weeks based on the half-life of the drug. Since IVIG is associated with infusion reactions and anaphylaxis, it's important to assess the patient history for previous IVIG use prior to product selection. Epstein-Barr virus, which is the virus causing infectious mononucleosis, is the most common known infectious trigger of hereditary or non-hereditary HLH. EBV is poorly responsive to antiviral agents, however, it resides in the B lymphocytes, which can be readily depleted using the B-cell targeting monoclonal antibody rituximab. Based on its efficacy in lowering disease burden in patients with B lymphoproliferative disorders, some investigators are starting to use rituximab to treat EBV-associated HLH. Rituximab is a humanized anti-CD20 monoclonal antibody that targets mature B cells and is an effective treatment for a number of EBV-mediated conditions. The dosing is usually 375 milligrams per meter squared, given IV weekly for up to 4 weeks, and this has been reported to be successful in studies. Rituximab is associated with a variety of adverse events, most notably infusion-related reactions, and thus it is recommended to provide pre-medication 30 minutes prior to infusion. A retrospective review in 42 pediatric patients with EBV-associated HLH who received treatment with rituximab-containing regimens was conducted. The median dose was 375 milligrams per meter squared for 3 doses. Treatment was associated with a 500-fold reduction in the EBV load and overall survival of 62%. Infusion-related toxicities were the most commonly reported adverse events. Thus, when combined with conventional HLH-directed therapies, rituximab improved symptoms, reduced viral loads, and diminished inflammation. Although disease reactivations can be treated with reinduction or reintensification of the HLH-94 protocol, persistent hyperinflammation or cytopenia warrants consideration of salvage therapies. Specific recommendations for salvage therapy are difficult due to limited data. Consultation with an HLH expert is strongly encouraged before choosing and starting salvage therapy. Options include, but are not limited to, alemtuzumab, which is a monoclonal anti-CD52 antibody that targets B and T lymphocytes and macrophages, ruxolitinib, which is a Janus kinase inhibitor, and anti-thymocyte globulin, which is an immunoglobulin that targets T-cell surface antigens. The combination of high-dose corticosteroids, etoposide, cyclosporin, emapalumab, and the use of additional drugs directed at the underlying cause, such as rituximab or anti-neoplastic drugs, may cause significant immunosuppression. Antivirals against varicella-zoster virus, antimicrobial prophylaxis active against PJP infections, and antifungals suitable for the prevention of aspergillosis are recommended. Weekly testing for infections or reactivation of pertinent triggers are recommended as well. Hemophagocytic lymphohistiocytosis, or HLH, is a potentially fatal hyperinflammatory disease that affects infants, children, and adults. HLH is usually described in 2 patterns. Primary or familial HLH is a primary immune deficiency. Secondary or reactive HLH is triggered by infection, rheumatologic disease, malignancy, or certain drugs or therapies. Primary HLH treatment focuses on combination chemotherapy as evidenced by the HLH-94 protocol, followed by stem cell transplant with or without the addition of emapalumab. Secondary HLH focuses on treating the trigger, and refractory HLH should focus on targeting key cytokines in HLH amplification loops. Now we'll move on to our learning evaluation. For question 1, which of the following CYP mechanisms results in a drug-drug interaction with cyclosporin? A. Strong CYP3A4 inhibitor. B. Strong CYP2D6 inhibitor. C. Strong CYP3A4 inducer. Or D, which is both answers A and C. So since cyclosporin undergoes extensive hepatic metabolism via CYP3A4, it may require dose modifications when given concomitantly with CYP3A4 inhibitors and inducers. So the answer here is D, both A and C. What is the mechanism by which emapalumab works? Is it A, neutralizes interferon gamma, B, directly inhibits IL-1, C, directly inhibits IL-6, or D, none of the above? So the answer here is A, as the mechanism of action of emapalumab is it neutralizes interferon gamma. What is the FDA approved indication for emapalumab? Is it A, emapalumab is not currently FDA approved? B, it's approved for the prophylaxis of PJP infections? C, treatment of secondary HLH patients? Or D, treatment of primary HLH in patients with refractory, recurrent, or progressive disease or intolerance to conventional therapy? And the answer here is D, emapalumab is FDA approved for the treatment of primary HLH in patients with refractory, recurrent, or progressive disease or intolerance to conventional therapy. Question 4, in which scenario is anakinra recommended to be administered intravenously or IV rather than subcutaneously? The answer here is D, which includes both answers B and C. B, thrombocytopenia. This is a relative contraindication to giving subcutaneous therapy, as well as if anakinra is given in higher doses, greater than 2 milligrams per kilogram per day or greater than 100 milligrams daily, it's usually recommended to administer intravenously rather than subcutaneously. So question number 5, which of the following therapies has data to support potential benefit in EBV-driven HLH based on its mechanism of action? So the answer here is B, rituximab. So EBV is poorly responsive to antiviral agents. However, it does reside in B lymphocytes, which can be rapidly depleted using the B cell targeting monoclonal antibody rituximab. So this concludes my presentation on hemophagocytic lymphohistiocytosis. Here are my references, and I appreciate you joining my presentation.